संजय और मनदीप को बोल दे अटेंड कर ले, पता उन्हें कुछ नहीं, फोन करके बोल दे बैठ जा तू काम। Yes.
So divorce.
Actually, you can say that. Usually not a problem during MS. But classically, deep retractor with a curvature which can be adjusted and a hook used for retracting deeper structures, like if you're retracting the muscles, organs, or liver. I mean, you can also retract bladder with it. It's a multi-purpose retractor. Have you used it? Your answer should be yes. In which surgery you have most commonly used it? In which surgery have you used it more commonly? Most laparotomies are in the middle of the night, trying to repair injuries. So laparotomies, then they'll ask you for what all you have done the laparotomies. Remember, instruments, specimens and x-rays are relevant only for those who are at the fag end of their exam and they have not done too well. So the examiner is trying to find some reason to learn something out of it. By identifying an instrument, you are not getting any mark. Everybody can identify a Devers retractor by this time. So they'll ask you what did you do, talk about the last surgery that you did. Okay, and you would say I was involved in a splenectomy or repair of a diaphragmatic injury or colonic injury or whatever. So that would be the use. But the idea is it's a deep retractor. That's the idea. Devers. Very similar, but it's malleable. So what you can do is you can give it a shape you want. You can give it an angle you want. You can actually make it straighter also. You can make it obtuse, acute, curved. You see, some people also use it for keeping the bowel out during APR. By putting it this way, they keep the bowel away. But it's usually with a wrap of gauze or cotton or something, so that you don't hurt. But this can keep the bowel in the upper part. Clear? Malleable retractor. Now this end can be used for hooking, this end can be used for holding, whichever end you want. Depending upon if you want a deep retraction, you can hold this way. If you want a superficial retraction, you can hold it this way. So no big deal about it. Malleable metallic retractor. And the advantage of it being malleable is you can give it a shape of a Devers. You can actually make a Devers out of this. You can make a leg and neck out of this. You can also make a Morris out of this. So it's a malleable retractor. But I have used it, and I'm just trying to share with you that both ends are broad, and you can actually put the bowel up during pelvic surgery, especially APR, and it works very well because it fits into the abdominal wall. Slightly bigger, into side mein, there's no space for bowel to sneak through. Now the advantage of one broad side, the other narrow side is depends where you want to use it. So it gives you that advantage also. So malleable metallic retractor. They are very similar, but this is broader than this, and it's got a curvature here. This is for a function. Langenbeck did the first cholecystectomy. It comes with that automatically. Now Langenbeck, when doing the first cholecystectomy, used it for retracting the part of liver which is where the bladder is, the gallbladder is, or the what you call as the plate. He would retract it, but he was constantly finding that it is not enough. Because what will happen with the retraction, the liver would keep falling like this. The part here, part here. So it did provide the space that it needed. Plus, it was narrow, so it could enter into the liver. Clear? Langenbeck's retractor. Now, what is this hook for in all these retractors? This is to prevent it from slipping. You must have seen most people when they're retracting, they tend to keep it flat, which is the wrong way to retract. It should be hooked. The advantage of hooking is you stay out of the area, and number two, you are able to get some space to work. Now, if you stay out of the area, the surgeon is able to, the person who is operating is able to see more. Against this background, his registrar, Morris, modified it, made it broader. If you look at it, it looks like a cousin brother who's eaten a little more. Broader, but there is a curvature here. Now, this curvature allows for negotiation of the structure, the right angle or scissors. This doesn't. And this being broader, I'm sorry, I was telling you about this hook first. So you retract it, it doesn't slip away. If you're hooking, it won't slip away. If it was flat, and if you're hooking, it will injure. The other thing was you could keep a piece of gauze here and make it completely atraumatic and retract the liver. And if you look at it from that point of view, Morris becomes even smarter. Broad, so the entire thing is taken away. You got actually, if you watch it carefully, the gallbladder is here. I have retracted the liver away. Everything is very clearly visible. And mind this curvature. This allows you a complete look at the common bile duct, the part which is above the insertion of cystic duct. And the hook doubles up as something which will not slip, and secondly, you can put a pad. I tell you, my guide was invariably asking us to put a pad here. It was a routine, which also became the most important cause of gauzes being left inside, and so it was abandoned. Liver was never retracted without a pad, which still is done. So these days we do it with a, you wrap either a abdominal swab or something, but it is a space for that. If somebody is asking you that question, you should know this answer. If he is not asking, don't worry. And on that day, don't try to give an answer which is not asked. Clear? Now the pad fits in here nicely, which protects the liver, and this hook allows it to stay, and the hook also allows you to take the liver out of the house. This is Morris and Langenbeck's. Morris is used for retracting the moderate kind of depths, but especially liver, rectus muscle, abdominal wall muscles. Now the back side, it has got the grip, which are fenestrations, broad ones. You can hold it like this. That is why the grip is. And what is this hole for? To make it lighter, which is the primary job. Don't say it's for the finger to be put inside. It's a wrong answer, but very commonly given answer. If a surgeon needs a finger to be inside a Morris to be able to retract it, he should not do surgery. It is not needed. You shouldn't get tired of holding it this way. This is the grip. Clear? Morris retract. Used for retracting liver, abdominal wall, deep structures, etc. Clear? Langenbeck's. See, the fenestrations have changed position. It is flattened. Because you don't need to apply so much of force. You just can hold it comfortably. Same function. You've seen it being used in retracting various superficial structures. It can't be retracting very deep structures. Journey spelt with C, and the hole inside is to make it lighter again. Don't give that answer. This is not good enough for finger. Just try to put your finger inside it. It's a wrong answer. Don't put a finger inside it. It's to make the instrument lighter. That's it. Okay. Now, why have two hooks here and a flat blade here? Again, to make it lighter and to have a variety. Now, This hole, this space, allows for the needle to be seen as it comes out, especially when you're closing the rectus sheath, when you're doing the mask closure. Mask closure is done with a Jenkins technique. Jan apostrophe S, which you all do. What is Jenkins technique? Gopal? Jenkins. Okay.
Continuous single layer closure of the abdominal wall.
Anybody?
So suture should be, so there are two aspects to it. Suture should be at least 4 times the length of the incision.
Very good. First of all, the length of the suture should be 4 times the length of the incision. Next.
Sir, the bite should be taken 1 centimeter
Away and not more than 1 centimeter from the previous bite. So 1 inch to 1. Third.
So the gap between the 2 subsequent bites should be.
I've already told you 1 into 1 centimeter. You're repeating. The first bite is the crucial bite. Now watch this here, rather than writing. This is the head end. This is the tail end. I'm retracting the rectus sheath, this entire stuff. The rectus sheath is the only thing left here. My first bite it inside out, outside in, at least 1 centimeter away and away from the last bite, the corner. I can't see the corner unless I have this. That is why it was devised. I am taking the needle inside out here. I'll come outside in here, so I need to see the needle, therefore this space. If I put it this way, watch it. Once the needle is gone inside, I can't see. I won't be able to rotate. But with this, I can. So I actually can take a bite beyond the incision. Is it clear?
Yes, sir.
Now, the needle would, this is a needle. Needle would come out here. I'll be able to see. Needle out, needle will enter here and come out here. I'll be able to see. That is why this. So the advantage of 2 blades, 2 hooks and 1 blade is, ये routine वाला है. Again a curvature, so that it doesn't slip away. Retraction means pulling and hooking. Pulling and hooking. ये किधर आ जाओ? Pulling and hooking. Okay. Now comes the space in between. It is to make it lighter. No confusion. Journey is done. This is the lung retractor. Don't bother about the name. Now look at its appearance. It has got a grip. You can't slip away. है ना, ये निकल नहीं सकते आप. But look here, it's very cleverly made. It goes up, down, and when you retract the lung, you'll be able to see still. Can you understand? This is used in thoracotomy when you're trying to reach the esophagus. Thoracotomy usually is right posterior lateral, and as you go through all the layers and you open the pleura, you go for the azygous vein, isn't it? Now when you're going for the azygous vein, this retractor is very handy. It has 3 major advantages. One is its location being, this is obtuse, this is acute. So what that does is, I have retracted the lung now and I am able to see clearly. Nothing blocks me. Secondly, this is light because of these wires, and this mesh allows the air-filled lung to expand in space. If it flat hoga, it will be traumatic. So air-filled bag. You want to puncture, don't want to puncture it. Clear? The grip is the key. You hold it in such a way that your hand doesn't go away, doesn't slip away. But retract it, you are able to see clearly. Is that okay? Now this is a lung retractor. That's all you need to know. Handle is strong. This is delicate, and this meshing is to allow for lung to expand, which is air-filled bag, and for you to see through it, because I can actually see much better if the angle is obtuse. अगर ये पूरा flat ऐसे होता मुझे दिखता नहीं. Clear? Can I move? This is joules, and joule is not joules. It is Joll apostrophe S. What is Joule's triangle?
So Joe's triangle is given, in order to see the external thyroid vein, we do the Nidus maneuver, we pull the superior thyroid wall and medially and outwards and expose the space of reefs.
The moral of the story is, whenever you read a comic book, read it thoroughly, so that you don't change a hero into a villain and a villain to a hero. You read it, I know from where, but read it well. I've given it in my own book and also in the 10 Commandments. Pulling the lobe down and out. Down and out. Can't be in. Listen to me. This is down and out. You open up the angle, which is a space of reefs. And this triangle, one side is airway, other side is pole, and the artery. This is called Joule's triangle. Joule's triangle contains external laryngeal nerve, not external jugular vein. And there is no external thyroid vein. Internal laryngeal nerve supplies what?
The sensory supply above the vocal nerves.
Both are branches of? Which is a branch of? Given at what level? ये खत्म ही होता है, सिलसिला खत्म नहीं होता. निखिल? इतने परेशान होने की जरूरत नहीं. It's exactly a centimeter above where the superior thyroid artery comes out of external thyroid. And if you're not careful there, you can damage it when you're dealing with neck dissection. Any of you are here? How many you lead in one case? 2. What is the limitation? Space. Joules. Okay. Now you would say mastoid retractor, which should be a wrong answer, because you don't have any reason to have a mastoid retractor in your kitty. This is a self-retaining cat's paw. It's a cat's paw, but it is self-retaining, which doubles up as mastoid retractor. Because why should you have a mastoid retractor? And it is self-retaining on account of this lever. Here, this lever. So if you want to make it function, used for superficial surgeries when you are alone. It gets rid of one assistant. So self-retaining cat's paw or mastoid retractor, दोनों बोल देना, so that you are safe. But superficial fascia muscle retraction. Some people, if you watch some videos, you've seen thyroidectomy also, they use it. The flaps they rotate, but that's a bigger one. I've seen one more which similar this thing, which is a spring action. ऐसे ही शक्ल का होता है, थोड़ा सा बड़ा, goes away. So that keeps the flaps quite far. It's very nice retractor. We use a rubber sling to retract the flaps, and we find that that's very effective, or the less flappity. Clear? So self-retaining cat's paw or mastoid retractor used for retracting superficial structures, and you can do without an assistant. Now, this one. Who's going to answer? Yes, Gopal. Why it is not a rib retractor? इतना बड़ा rib retractor नहीं चाहिए. So let's look at something where you have to go into the cavity that deep. It's a self-retaining bladder retractor. Used in the past for prostatectomy. Limbs होती है open, use होता है ना, ऐसे खींच के करते हैं. Once you made an incision in the bladder, how do you recognize bladder? He'll ask you this question. That's why I'm asking you. When you're doing cystostomy, cystolithotomy, or prostatectomy, you make an incision in the midline, then you reflect the peritoneum, don't you? So how do you recognize the bladder has come? You are first. Are you answering? You're not answering. Okay, Deepak.
There are many superficial veins present.
One is veins, the bunch of plexus of veins. It is vesical plexus of veins.
And transverse ridges of the muscle is visible, white.
Very good. Transverse ridges of muscle are visible. Third
We aspirate urine.
Third is you put in a needle and aspirate urine. Don't put a knife before you've done these three. Clear? Now, after you made the incision in the bladder, watch it, what I am showing. This end is towards the pubis. This is how the opening is, not this way. It's a favorite question of old examiners. ये head end है, ये foot end है. It's the wrong way to put it. This is the right way to put it. All retractors which are self-retaining and are taking care of pelvis, this should go down where you are not going to see it. You should only see the bladder. Now once you retract, now this is the head end, the foot end. Now it is retracted and the bladder is visible to me. I will see the orifice, I'll look for the trigone, and I can actually do the bladder neck release also by making an incision under vision, or I can actually go for prostatectomy. So this is some people call it Millen's self-retaining bladder retractor, but I am calling it simple self-retaining bladder retractor. Okay? This cannot be for the ribs. You don't need such a deep one. Anybody with doubt? You don't see it these days, that's why there is a doubt. This can be one assembly or it can be separate. Now what is it?
Balfrost-type self-retaining abdominal retractor.
Along with doins it comes, which needs to be fitted into this, and you can actually use it for retracting the bladder. Even in hysterectomy, the same purpose. Basically use it for retracting the bladder. And the whole assembly is very effective, and you can actually do without one assistant, definitely. The bladder goes down. Again, you would have seen that we put it wrongly in the abdomen. It comes on the chest wall, but actually it should not be in the field where you are working. That's the whole idea. Chest wall retractor भी एक था, hardware गया था. Students सारे बड़े. If it is given individually to you, some people call it doins. We don't need doins, so you can call it a part of the self-retaining Balfrost, where you are retracting the bladder with this. Clear? This is an individual cat's paw. You saw a self-retaining. This is an individual cat's paw, which is used for retracting soft tissue fascia superficially. Okay? This is not a retractor used, wrongly used as single hook. It is not single hook retractor. It's a skin hook, which doubles up as a nerve hook or as a vascular hook. What will be the vascular use of this, Mandeep? What did I say? Nerve hook, skin hook, vascular hook. यहाँ पे एक slit है इसमें. This is for the grip, so that you stay away from the field. It is used for harvesting the 4O, 5O sutures and keeping them all on the hook. You take a bite, putting it on the hook, because you can pull it at the end. All of them are on this, and they fan out like this actually when you hold it. And you release one, pull one, release one, pull one, release one, pull one. So this is used for vascular surgery also. It doubles up as a nerve hook. You can retract a nerve also with this. But not used anymore. Why? Because the angulation. Because it's a very thin thing. I use vein hook for retracting a nerve. क्यों एक दीपक वेन हुक यूज करते हैं ना हम रिट्रैक्ट करने के लिए, तो कारण यही है ब्रॉड, so it won't cause neuropraxia, angulation injury. With this there is an angulation, but suture can be taken. You see, you are getting if you're getting all those sutures in the depth, lots of vascular sutures in the depth, we can use it for harvesting one by one. And actually it's a very smart way to take multiple sutures, but they're kept loose on this. And you can actually take one out and make sure that you are able to close it adequately. The leaks are taken care of in vascular repair. Then nerve hook and also skin hook. और कुछ निकाल ले नहीं है ना कुछ, अब आगे चले. This, the moment you look at it, this is the depth for the chest. So it has to do with the ribs. Its shape, appearance, everything. It is to bring them together. If you reverse it, it can take them away also. But it's to bring them together for closing, approximation. So rib approximator. Getting it? After thoracotomy, if the rib is missing, you bring the other ribs together so that you can then put steel wire or proline or whatever you see now. This is how it works. And the curvature allows for the rib to fit in both sides. So you can actually cover up a defect of up to 2 ribs comfortably. So rib approximator. If I reverse it, it will be a rib spreader. दोनों तरफ hook उल्टे हो जाएंगे, it will go the other way around. Clear? Yes. Used for closing a thoracotomy by bringing the ribs together. Alright? Retractors are done. Lie. Double hook. This has a space for finger. Retracting the superficial surfaces, skin, tendons, fascia, but tough structures because it's going to hurt. And it's been made lighter by giving slits in the center. This is a rib respiratory and it has serrations on both sides. Can you watch this? Which means the grip. You are supposed to hold it here. The which side respiratory is this? Hold it in your right hand. Hold it in any hand. This tip has to look at you. Presently it is looking at Nikhil. Left side. You should see the tip. Rib respiratory is a kind of a periosteum elevator for the rib because you can't go around the rib. This goes around the rib. So how do you introduce it? This is the rib. You will create some space subperiosteally. You see, the safest approach in bone is to go under the periosteum because there is no structure there. You will damage, if you go over the periosteum, you will damage the pleura, you can damage the other structures, the neurovascular bundle. So if you don't want to damage it, give a small incision in the periosteum and lift up the periosteum a little bit and then introduce this around. And now you can see the rib. The usual motion is towards you. Spread it, spread it, spread it. So you'll create you need only a small lick to enter. Then the periosteum is elevated. That is why periosteum elevator is used. Periosteum elevator is used in orthopedics very regularly because the entire approach in orthopedics, if you stay under the periosteum, you don't need to do training in orthopedics. There is nothing you can damage. And it's not a surprise that there's still damage. If you stay under the periosteum, you will damage nothing because actually there is nothing. If I have to reach one end of the bone, the other end of the bone I can reach by getting under the periosteum. Keep just lifting up the periosteum. Everything will go away. Remember, therefore, rib respiratory is nothing but a periosteum elevator for the rib. And you should not cut a rib with periosteum on it. Why?
Beneath there is the van structures will be there.
One answer I have given you because you will damage something which is what he is repeating. Second is
Vessels. Feeding perforating vessels will be intercostal. Intercostal vessels.
I have already said that all the vessels, pleura, they are outside the periosteum, so they will not be damaged if you stay under the periosteum. वो तो जवाब हो गया ना. The other thing is the only sensitive part of the bone is periosteum. It will cause pain. Periosteum is the only sensitive part. Osteomyelitis becomes acutely painful because periosteum is stretched. Bone is insensitive to pain. If there is no periosteum, you can cut the bone, you can do whatever with it. Nothing happens. Therefore, when you are putting a Steinman pin also, the skeletal traction जो लगाते हैं, skin में देते हैं infiltration, then you give in the periosteum. उसके अंदर जो bone के through जब जाता है वो कोई pain भी नहीं होता, फिर उधर निकलने वाला होता है, फिर देते हैं local. ऑर्थोपेडिक वाले नहीं, मतलब जो नॉर्मल लोग हैं वो तो देते हैं दोनों तरफ. ऑर्थोपेडिक वाले कोई लोकल फोकल कुछ नहीं हो तो करना ऐसे ही है. But the idea is the same. Periosteum should be anesthetized because that is going to hurt. Similarly, in the abdomen, peritoneum should be. Pleura in the chest. These are places that are very, very sensitive. The rib respiratory of the left side. Okay? Don't say rib respiratory of the left side, say rib respiratory. If he is asking, then you get a chance to explain. और है कुछ ये रहा. This is periosteum elevator of a different kind, which is used for the same purpose. What is its name actually?
Parabox. Parabox periosteum elevator.
Huh?
Parabox.
This is not parabox. That's why I'm saying just call it periosteum elevator. It's a different one. That has a acute curve. Doesn't have it. Periosteum elevator. That's it. And this is for thumb to rest. So it should be used with the thumb on it so that you are able to strip the periosteum. Clear? And again the same reason, you want to lift the periosteum before you cut the bone. हो गया रिट्रैक्ट सब हो गया ना. चलो अब इंस्ट्रूमेंट्स फटाफट. और भी दे दें सब सिर्फ ये okay. We'll stick to the same description for all the artery persons. Kelly है. There are three basically. Mosquito, medium and Kelly or large. The Kelly is not just that one which you see in your emergency OT for putting the brains, the long one. Well, that's the most common Kelly that we use. Kelly is the larger hemostat. Okay. Now we'll take the description of only any one of them. It is a medium-sized artery forceps or hemostat, which has got rings at the back, more than one ratchet, so that only one is to be used, box type of joint, and transverse serrations which make it traumatic. It is curved, so it's a curved, medium-sized hemostat, or artery forceps, or a clip. They all mean the same thing. Clear? Use only one ratchet and try to enter just about into the ring. Don't go far, because then it will be difficult to come out. Clear? And the advantage of curvature is you should see what you're tying. Because you want to see the tip. See what you tie and tie what you see. That's the principle of surgery. See what you tie and tie what you see. And having more than one ratchets indicates that you want to use only one. If you use all of them, tissue will be crushed and the instrument will be damaged also, because then you will gradually lose that the functioning of the ratchets. The same description but a smaller size instrument. It's called mosquito because of its size, and it's got same a couple of ratchets at the back, transverse serrations, box type of joint, small and curved. Again, you would like to see the tip, therefore the curvature. To open up or to release an artery forceps, don't struggle to push it. You have to use the principle of using the thumb and the ring finger. Thumb up, ring down. Right? If you do it, the other method is by using the palm approach. In the left hand or in the right hand. In the left hand now, your thumb down, ring up. These are the two approaches to open. You don't need to struggle to crush the tissue and before you come out you've taken the tissue also out. That's not correct. You will take one ratchet and then watch which side you are. This is going to go the other way around. So you would use the left hand. It will automatically be thumb down, ring up. I've done thumb down and ring up. Okay? If you want to palm it and do it, you can do it the palm way also. Mosquito, medium. Clear? Same description except that it's a straight one. The transverse serrations improve the grip, but they are traumatic. So there is increased trauma, although the grip is better. There are a couple of ratchets, there are rings at the back. It's again medium sized but straight. So it will have a disadvantage of not showing you the tip while you're putting the suture, tying. Curvature would have helped you. So therefore it is used on the surface. Where else you can use it? Suppose there is a small structure that you are going to cut, ligate and cut. You want to put the clamps, you can put straight ones so that there is space in between. Okay, you can put the curved ones also, but the disadvantage is at one end it will be less, another end it will be more. There is a risk. So both being straight, you can put it, and it's easier to then cut it. Straight, curved, and the size difference. They both would qualify as medium. This is mosquito on account of its size. And the ratchets, not more than one to be used at a time. The fact that they are more than one. And just about into the ring and box joint. Rest all is similar. Similar approach in description. Rings at the back, ratchets. Here again, you would understand, being more than one, here also, it indicates that longevity is important. Because if you were to use, otherwise there will be one only, here like it's only one. You can do with one also, but after some time it will lose. So it's much better to have 2, 3, so that you can gradually keep on using it. Then you have something here which is important. The serrations are crisscross and there is a slit in the center. This is for the needle to sit in nicely. If the serrations are only transverse, the problem would be the axis, which is vertical, would be not neutralized, and that will have a disadvantage in the grip. The needle needs to sit somewhere comfortably, because if they are only transverse serrations, the needle is tending to go either way. So with the crisscross serration, that won't happen, and with the slit, it will definitely not happen. That's where it is different. Because if I hold the needle with a straight artery forceps, which you sometimes do in minor OT when you don't get the right kind of a needle holder. The disadvantage you have is there's only one axis that you have, so it is not taking care of the turn, the rotation. So it is not a very good approach to have a. I mean, therefore, it's preferable to have crisscross serrations, and if you can have slit also, that's ideal. So not all needle holders have slit. Some very small needle holders, especially in vascular surgery, they don't have a slit because it's too small to have a slit, but they have crisscross serrations. Now this again, don't call it mixture, it will be wrong. Mixture is a different instrument. So just call it, same description, rings at the back, ratchets not more than one to be used, and the serrations are transferred, so it's actually a hemostat with a curvature and at an angle that you can get it in an obtuse angle. If it is a little more acute, it will be fitting into mixture, but it will serve the purpose. It allows you to see the tip when you're passing through from depth, and you can feed a suture through it. You can also dissect with tip up. The advantage is you will be able to see the tip all the time, which is necessary. And also when you're going along the cavity, you will be able to see the tip. What is this instrument? If it's a Cali, nobody will kill you for that, but it is not Cali. It's actually a clamp. It can also fit into a cholecystectomy forceps and a clamp because it has got an eye, if you notice. Very few people notice that, so let's not get too much into it. It is for feeding the thread through. After taking one transverse bite, you feed the thread through that. It's short end. Not used for that purpose anymore. But this can be a cholecystectomy forceps. What is the advantage of cholecystectomy forceps over sponge holding when you're holding the gallbladder?
Pressing the gallbladder wall.
It's at an angle.
Yes. If you're holding the Hartmann's pouch, which is what it is for, then the sponge holder will occupy the space in a broad sense. It will not give you space to work. And remember, when you're doing open cholecystectomy, the intention is to have a traction down and out in the line of the cystic duct. So it will hold, say like this, and another one here. So this actually will be pulling in the axis, only in one axis. With that, the whole space is occupied. So the basic difference is the space it will occupy is less. If this is replaced by a sponge holder, imagine the broadness of here, and you are not able to dissect in this place. So it is an advantage. Secondly, it can serve as a right angle that you see. So it doubles up for both the functions. Some people use only cholecystectomy forceps, and they do what? They hold the duct in this, and then they cut the gallbladder. Many people do that, and they tie. So they clamp and cut. So for that purpose also it's useful. Primarily, vis-a-vis a sponge holder है बेटा? ये गेज है, चलो. Broader, that's it. Is that clear? So it can double up as just mention it as a Kelly clamp or a cholecystectomy forceps or just a clamp. Just describe it and it's usually enough. But it's heavier or stouter than an ordinary Kelly. Kelly is thinner and sleeker. This is heavy, so it's used for holding the tough structure. Clear? The grip is solid. Like, see, if I was to hold it, this is the Hartmann's pouch. एक grip ये, vertical in the axis. And that's what I'm trying to say. If you hold it with a sponge holder, it has no axis. Straight. So you're getting my point. You can go farther on the gallbladder and yet put it in this way. So that's it one. Something similar. Again a clamp. Why? Because you can see a slit in the center. And what is the purpose of the slit in the center? You don't know? Oh, this is traumatic. You want to test? Now the slit actually converts it into two clamps, two grips at a short distance. It's a firmer grip. Isn't that very clever? You can see that showing it for his recording. He's recording it. There's a slit here, and this slit would make it into two. So it's a 2-in-1 clamp. It's vascular, or if it's a vascular thing which you're holding, a pedicle, wrong. This is basically for pneumonectomy or nephrectomy. You put it this way. Now, the same pedicle is being held at two places. It's a firmer grip. Now, what is the advantage? Why did I say it's a clamp? Watch the shaft. Watch it now. They ride over each other. So it will go inside like a stick now. You getting my point? Unlike this, which is broader. This is something you'll get into this. Here it's just a stick. And there's nothing in between. Sleeker. Goes inside and doubles up. Nothing goes anywhere now. It's like putting two clamps. Because after all, what is the difference between one and the two clamps? The blade, no? बाकी तो आपको गिनना थोड़ा ही है. Blade ही तो है ना difference. The difference is that there are two blades. Two blades like this. Now, if you join the two artery forceps together, tie them together, they'll still remain two. So this backside is what is not significance, but here there are two of them. That's a smart way to achieve. Double the grip, so stronger, and it's a pedicle clamp. This would be Kelly, no, Cockles, right? Now, this is a medium to large sized instrument with rings at the back and the ratchets, which are more than one, same purpose, transfer serrations and the tooth. What is the purpose of truth? Where was Hold down. Cocker, where did he use it first time?
Appendix.
ये appendicectomy. You mean इससे पकड़ के निकाल दी थी? This was used for thyroid surgery, and the superior pedicle was held with this. When Cocker started, this is the superior pedicle. Watch it. Now it can't slip away. If I put an artery, it can slip. Actually, it did slip. Yeah. And even if I try it, can't because there is a hook there. So he made it for the superior pole. And those days poles were to be ligated as one. There was no superior thyroid artery dissection that time. No Nias maneuver, no angle of Joles, no Joles triangle, no space of Reeves. It's a baat ki baat hai. Now this was the purpose of. This is where he used it for the first time. Then you used it for crushing. You also used it for ARM. This is coccus clamp. Now we use it when we put that feeding tube across the pectoralis minor during level 3 dissection. उसपे हम यही यूज करते हैं जानबूझकर कि वो स्लिप नहीं करे, won't go away, otherwise it will slip out of it. That's the purpose. Clear? This is coccus. Cocker means thyroid first. That's what he did almost all his life. Now, similar, long curved Ellis forceps. Not valsalem. We don't need valsalem in surgery. Long curved Ellis forceps. Long curved Ellis forceps. And it's also used for holding tough structures, the upper cervical lip. Cervical इसलिए होता है पता है क्यों? The advantage is you can hold it and pull it this way, so visibility is better. See, the angle takes care of direction, but we are not using it as valsalem, naturally not. So this is a long curved Ellis forceps, used for holding tough structures, pulling them out while you want to see the structures in the grip. That's the advantage. Okay. And this is a classical Ellis forceps, which has got ratchets at the back, crushing teeth in front, and there is a space in between. It can be used for multiple purposes, holding tough structures, right, and also getting tubular structures in the space and lifting that up. And there is a box joint, the ratchets, depending on what you are using it for, has to be one. It is traumatic. Often confused with this, which is a Babcock's tissue holding forceps. Ellis tissue holding forceps. That's what tough structures like tendon, fascia, subcutaneous tissue, never skin. Babcock's for soft structures, and also for lifting up tubular structures in that space. Vas, okay, tubes. Same, everything else is otherwise just the same. Box joint, there are ratchets, rings. And the other thing is the space here. If you notice, there is a space for the structure to expand. So you can take structure more than the size. Appendix. Isn't it? Babcock's tissue holding forceps. This is sponge holding forceps with the rings at the back, ratchets which are more than one. Then the interesting thing are the blades, which are circular and they have transverse serrations. So it is crushing, traumatic. The grip is good. Used for holding sponges, gallbladder. You can also hold cervix with this. Box joint. Clear? Sponge holder. Some people use this to hold structures that are going out of the body, like neck dissection. A lot of people, when the cryle started, earlier days surgeries, they used to make a small lick along the trapezius to cut the fascia, right from the apex to the base of the posterior triangle, and then they lift it up and peel it off with the fascia. The entire thing would come out because they were not preserving accessory then, and it will come off as one little envelope. Same thing in the axilla. Some people do an envelope axillary dissection. They hold the whole fascia, cut it, lift the whole thing out. But then you don't preserve anything. You will have them going through the envelope. This is sponge holding. This is tongue holding और lung holding. Tongue holding तो होगा नहीं, वो भी होता है ऐसे. Lung holding. Why? It is very fine serrations at the tip. And then what is the space for? Again the same thing. For the expansion. And also you must have seen Calesian forceps when you were in ophthalmology during your MBBS time. Calesian बीच में लेके so काट दीजिए, serves as a clamp also. So many a times in the lung especially when you're doing thoracic surgery, there is a small little nodule you want to excise, get a nodule in the center, cut, remove it, and then you can put running sutures all around and pull it. So it can be done. It's very, very useful instrument. But primarily lung holding forceps. But it doubles up as tongue holding forceps because in the tongue also if you take a biopsy, removing a tissue, get that in the center of it and with a sharp blade just cut around. No bleeding would happen. And then take running sutures. Nikal do. What is this?
Systolithotomy.
This is cystolithotomy first. How do you hold it? Same? Yes. Most people do it this way because initially जैसे इसने पकड़ा, ज़्यादा ठीक लगता है. Let's hold it this way. It's the wrong way to hold it. The right way. And what should be the curvature direction? This is the foot end. It should go in like this, feel the stone, grip it. Why is it important? Because with the curvature that side, removal is easier. I've used it in plenty of patients. That's how I know the difference. You're just theoretically appreciating it. I'm practically telling you there is a problem. If I go this way, I can't get the stone out. It goes this way. Close. You got that retractor in place or not in place is not a problem. And you feel, you get actually a sound. You sound the stone. फिर उसके आसपास थोड़ा इसको इलाज करके adjust करते हैं. Then gets into this. And then you. I have seen initial hiccups with this. People are out of the bladder because they're so anxious. Because it used to be one of the earlier surgeries of house surgeons and first year PDs. That they're out of the bladder, then they drop the stone. Then the stone goes places. Then starts the real wild goose chase. Systolithotomy took only 20 minutes. And the searching for the stone spent a lifetime. And there are case reports of a lost stone being found. It used to happen. There won't be X-rays to check out. They keep searching. The recesses it disappears into. And you'll be very surprised at the recesses the body has inside. Stones just disappear. आप दुनिया भर की ढूंढ लो फिर कुछ नहीं मिलता. Therefore, the grip and the whole thing has to stay absolutely steady, and it's possible to the curvature. Why do I say systolithotomy? These hooks, they hold a grip. Most of the times, the stone that is removed is oxalate stone. How does it differ in appearance from the phosphate stone?
It's a irregular surface.
Oxalate is mulberry. Oxalate is a mulberry stone. And that's why it's detected early. That's why the prognosis is better. There is hematuria early. Phosphate presents when kidney is gone. It produces hydronephrosis and then you come. Oxalate, strangury, hematuria, irregular surface, pain, they come early. And that oxalate, that mulberry fits into this. That's why. लिखो Desjardins. Corridopolithotomy process. And now cut it. This is wrong. अब शुरू से. Now this is an instrument without any ratchets, with no box, with a curvature which can never get into CBD. with blades which have got serrations, which is never used for a CBD stone. It's a nephrolithotomy or a pyelolithotomy forceps. ये मैंने आपको जो 3 difference बताए हैं, these are the basic differences. Disjardins, now listen to me carefully, don't keep noting it down. Disjardins would be the same instrument straightened further with no serrations here. The CBD stone is very soft, it will get crushed. And you can, इतनी बड़ी CBD होती है, इसके आगे कैसे जाओ? That whole thing is straight, it goes in. It's almost straight, like this. इसको इसके रूप में देखिए. Try to see with this curvature. That is Disjardins. This is nephrolithotomy or pyelolithotomy. And what? There are 3 angles. Watch it. This is acute. There is an almost 90. There is an obtuse, and there is a straight one. The lower calyx, middle calyx, you can remove with this. Also the lower calyx. With the kidney in your hand, right side, I'll be entering like this and sounding the stone, holding it. This is for pyelolithotomy. This is not Disjardins. Clear? Bone nibble. अगर nibble कर से Whose bone? Nibble कैसे करेगा? तो पकड़ने में तेरा दम निकल रहा है. Nibble तो तू तब करेगा जब पकड़ पाएगा. It's so heavy. Remember, bone nibbler has to have a lever, which it doesn't have. Lever which functions in nibble. And it shouldn't have those cups. But bone nibbler is there to be seen. I can show you if it is there. This is a bigger bone cutter. There is a ring like this. Sorry, there is a spring like this which functions for nibbling. Nibbling इसको पकड़ के कौन खींचेगा? Bone को इससे अपने हाथ से करेगा nibble. This is a bone holder for larger bones. You reduce fractures by not holding the bone in your hand. Watch it. This is femur, lower end. This is upper end. This deform. Similar instrument here. Then they are brought together. Done. Now Bhavani will hammer with the K nail. From there I'll keep on holding. And both the orthopedic surgeons will be jerking all the time. Daga, daga, daga. That's all they do. And when it goes through the fracture onto the other side, I will know, because this will start shaking more now. And then roughly we'll decide, both of us, now enough. And that bone is covered. And that's the purpose of a bone holder. It is helpful in reducing the fracture while it is being fixed. That's the correct answer. And it is not a bone nibbler. You cannot nibble a thing with this. For nibbling, you need a lot of punch in the instrument. समझ गया? ये नहीं. This is a bone cutter, which has got double lever. Watch it. One here. See. This is what generates that power here. Not you. You can't cut a bone with your hand. Nobody can. You can't nibble it also. That is for grip only. But the whole power is of the lever that you are using. So this is a bone cutter. There's one mallet's bone hammer. It used to be here. I think they removed it. चलिए जो है वो. This was there, but we did not take it early because you can confuse it with a skin hook. It is not. Single loop retractor it is not. It is actually with a eye here, so it's an aneurysm needle. But you can pass any thread through even cystic duct, around cystic duct also. This is basically used in aneurysm because it will occupy less space. I use a right angle even here, mixture, because I find that easier. There are sharper ones and smaller ones now, so we can do that. But this can be used for passing thread around the superior pole of thyroid artery also. Superior thyroid artery also. It can be used for anywhere where you can pass the thread. But its name is aneurysm needle. And it has a grip which you can use for dissecting and negotiating the thread. Clear? This is Macos towel clip. This other one is Mayo's, which is not here. Which one is this? Lane's tissue holding forceps, which is very similar to a towel clip also, shorter. Again, it has, the only thing it has is sharp tooth, which digs into the tissue. So it is a tissue that is going out of the body. You don't hold anything with this, which is staying in. And it is space for expansion. Ratchets at the back, holding tough tissue which is going out. This is an instrument which is spring loaded. Where is the spring loaded? Here. Spring loaded has an advantage, it has a memory, which means it will go back into the position from where it came. So it can be allowed to expand into tissues also. And the grip is the fenestrations which are on the blade. And the classical grip is between the index finger and the thumb, resting on the middle finger. And to make it function, I have to make the spring function. When I leave it, it goes back to its position. So it has a memory. That is what is needed. The tooth makes it a better grip, but traumatic. Better grip. Everything similar, no teeth, makes it less traumatic, but less grip also. The grip is also weaker. Now this one, with the tooth, is used for holding tough structures, skin, fascia. This is used for holding soft structures. Clear? Plain and tooth forceps. No confusion about that. This is an instrument with rings at the back, no ratchets, and a box joint or a screw joint. It's a screw joint. And the fulcrum being close to the tip makes it a surgical scissors. If the fulcrum was in the center, it will be a tailored scissor. जितना fulcrum tip के पास आएगा उतना fine cut. इसको अगर आपको improve करना है as an instrument, take the fulcrum further up. The closer the fulcrum is to the tip, better the cut, finer the cut. Now the only problem of this instrument is it is straight, so you cannot see the tip all the time. So we made it curved, which allows the tip to look at you all the time. So tip up or tip towards you. That's how scissors must be used. And also you can use it for dissection. Tip up approach. Therefore it's called a dissecting scissors. Remember, cut what you see and see what you cut. Tie what you see what you tie. That is why curvature is necessary. Most complications in surgery are because of not following this principle. See what you cut what you see, tie what you see, and see what you tie. तो बाकी समस्या अपने आप ठीक हो जाएंगी. अक्सर तब होता है ये तो कुछ और निकला, कुछ पता नहीं था क्या करना. And broader the blade, more the dissecting value. So if you have to make it, this is actually Mayo's scissors, but don't get too much involved into it. The broad bladed heavier one is a Mayo's scissors, but just remember straight and curved. And the difference between a scissors of a tailor and that of a surgeon, and curvature, see what you cut what you see. Okay? This is a clamp, which has got same thing, ratchets at the back. More than one means you're going to use only one. The blades have serrations which are horizontal. which makes it relatively less traumatic. But the grip is also poor, and you can also see some daylight through it. So it is relatively less traumatic. Don't call it atraumatic, less traumatic. So it's a bowel clamp. Don't use this. Use one. Especially in the surgery in emergency, bowel is the dimetus. Use only one. It will be okay. Otherwise, ischemia would happen. The longitudinal serrations allow you for it to hold, but it's not as good a grip. You must have seen bowel slipping away from the clamp very frequently. And many people use vascular clamp for bowel anastomosis to hold the bowel. And I found that is more traumatic, the ones that we have. So, the best I've made them do sometimes the fingers, hold with the fingers. That's the best, the least traumatic. Otherwise, everything is possible.
So just like this, another clamp is curved. This is straight.
So, curved bowel clamp.
Is there any basic difference?
The basic difference is curvature would allow you to take the depth, especially when you're doing a resection, say from the rectum. You put a curved clamp and you cut like this, so you were able to take the bites better. One, it allows you space for taking a bite. Two, number three, especially in the mesentery, sometimes when you're taking the bowel in a particular manner, it helps to have a curvature. Curvature everywhere in surgery has an advantage that it allows you to see. So straight and curved. And sometimes to differentiate between which one is going, which one is staying, you put one straight, one curved. Same thing is applicable in doing hemorrhoidectomy. Skin, some people hold with the, not skin, the inner part of skin, with the straight and the other with the curved. So you always know, ye straight, ye curved space. But primarily the clamp, straight is used say in gastrectomy. Curved is used in bowel anastomosis because it allows you space for working. You have to anastomose with the clamp in place. What is this? Suction cannula. Don't give it any other name. There's an opening now. Yeah. Yeah, I can see. What is this opening for?
Negative pressure while occurring.
To increase the negative. Not that it will not function. But if you press it, it will function further better. Humvee skin grafting knife, they'll ask you what are the types of skin graft. Split thickness skin graft, where you just take epidermis and parodermis. Full thickness you take epidermis and dermis both. Full thickness has the advantage of strength and pigments. So it will cosmetically be good and it will be stronger. It will put on the fascia, tendon, whatever bone. The disadvantage is poor take-up and you can't get a lot of it. Split thickness advantage, good take-up, you can get as much as you want. Disadvantage, no strength and no pigment. खत्म हो गया, इससे ज़्यादा बात नहीं करें. And ये उससे अच्छा है जो होती है. उसमें अक्सर दिक्कत होती है. उसको रिप्लेस कर. है ना वो टेढ़ा तेरा लगा 4-5 बार कोचिंग की हुआ है. ये ठीक है. यहाँ कैसे है? लगे तो इंस्ट्रूमेंट सबसे पहले 15 साल पहले करीब एड कलेक्टेड उससे रिप्लेस कर दे इसको मौका देके तो दिखाने के लिए है ना तो दोबारा करेंगे उसमें क्या Janus Veris needle with a spring. The spring ensures that when you're entering, you don't traumatize. And the classical way to hold it is when people hold differently, no? Should you hold it here or you hold it here? And angle, you create the angle with the medial side of the palm on the abdomen, okay? Then how many times you have to go through the abdominal wall? Twice. Even if it is just below the umbilicus. It goes twice. It's halfway between umbilicus and Pubic symphysis, that there is no posterior sheath. Otherwise there is sheath. Although just close to umbilicus it is merging. But you should break the resistance twice. Check for negativity by putting some saline drops which get sucked in and connecting it for negative pressure in the monitor. इसमें तो कुछ बताने की जरूरत नहीं. I think it is simple. Open trocar is preferred so that you don't enter anywhere blindly. Asymptrocar बंद करने क्या? चेक करना राजकुमार उनसे बड़ी उसी के लिए वो तमाशा करते रहेंगे. Trocar grip. It is stopped by palm, the grip, and rotating. What is this?
5 mm.
Sheath. Huh? तू हंस रहा है सबसे ज्यादा इधर में इधर. तो पुरानी वाली सीजर था ना, पहले जो कोलोसिस्टेक्टमी यूज करते थे एज ए प्ले. मुझे याद है ना पुराने प्ले है ना ये ना. लैप्रोस्कोपिक एंडोसिस hook. ये खराब तो मैं देखो क्या था ये ग्रास पर. बताया नहीं ग्रास पर ही है. सभी टूटे हुए हैं, रखने ही चाहिए. Any questions? Instruments are over. Anything you want to ask on this? Suction rate. लाओ तो थोड़ा दे जल्दी दे टाइम. What is it? It's Bhavani. Now there is a line here which is a radiopaque line for you to find it on X-rays, which is important, and it also goes along the eyes, so you can actually see the last eye is inside, which is so important to see, right? If it comes out, you will know with the X-ray. That's true of all of them. Chest tube, Foley's, indwelling catheter. What is this? Gopal? Now, what is this for?
Fixing.
What is this for? What are these wings for?
Fixed with the skin.
By strapping or suturing? This is for suture, that's why it is there. For suturing through this one skin. Or you can also put a tape around and tie it, but that is usually for the metallic one. And this is to inflate. How much is the inflation you need to do?
3 mm.
Standard है, nothing much here. दिख रहा है ना इसमें ये आई का जो बता दो. I think this is usual. The sutures there. Careful. What is it?
Cutting. Reverse cutting. Reverse cutting.
What is reverse cutting?
That's the pinch of the triangle at the outside of the, so on the convex part of the.
How does it help? What is the purpose of reverse cutting? अरे
goes easy
Tough tissue can
Tough
be-
tissue.
Cutting is normally for vascular processing.
Reverse cutting for vascular. You don't use cutting for vascular, firstly. Reverse cutting is with the cut that happens inside so that you can go wider without going wide. You see, when you are taking a bite, the usual appearance of a needle is the sharp is outside, so you keep going farther. If the sharp is inside, then you are able to take the thread beyond because you're cutting inside. So you take a wider margin without losing the tissue. That is the purpose. Padho usko. I'm not discussing theory of it. And no vascular sutures are cutting. Vessel doesn't need it. Reverse cutting is used when you are trying to get, you're putting it close, but you want the width also at the same time. And how wide should be the bite? Twice the depth of any wound. Vicryl is a monofilament or polyfilament? Polyfilament. लिखो. अब काटो. It's a virtual monofilament. That's the best way to remember. Write and cut. How does it become a virtual monofilament?
It's covered with
Yes, it's covered in a sheath. So it becomes a monofilament. So it's virtual. It's a virtual monofilament. So polyfilament right, monofilament also right. So beech ki baat. Virtual monofilament. Silk is non-absorbable natural suture. Synthetic non-absorbable would be nylon, which is New York, London, which is the first non-absorbable suture that was used. After that, they are derivatives of New York, London. New York, London suture came into use during Second World War, and the supply to US stopped from Europe. So they created, Allied forces, they created their own suture, which is a nylon. Nylon doesn't disappear ever. It will remain even after nuclear holocaust. That's what he said. Which is good and bad, because the problem is it stays in the body forever but doesn't have the tensile strength. So why do you need it? Proline has a tensile strength for a longer time. It also doesn't go anywhere. So then came proline. But even proline is not good. The best suture is, the ideal suture should be absorbable. It should be monofilament. It should cause minimal tissue reaction. It should be antibacterial. And it should be cheap at the end. That's very difficult to get. This is Moynihan's, Sir Moynihan's definition of ideal suture. So whichever is closest to it. So PDS, polydaxon, that is absorbable with a tensile strength of up to 6 weeks, 6 to 8 weeks. Vicryl is 3 weeks. So if anybody is closing rectus sheath with Vicryl, he should be hanged with Vicryl actually. So that the death is also slow. Single string. Vicryl cannot be used for closing rectus sheath. Gynecologists use it very quickly. That's why I am giving the example. And gynecologists are taught this. I take their courses and I have to tell them specifically Vicryl, rectus sheath, no. हम तो अक्सर यूज करते हैं तो चलता है, हम तो यूज करते हैं, आपको थोड़े आता है इंसिजन आइए. Monofilament suture is ideal, absorbable, but with a tensile strength for the tissue. So when you are using a suture, you have to take into account 3 things. What is the tensile strength you need and for how long you need it? When can the suture disappear? Vicryl disappears in 3 weeks. Am I right? How long does it take for rectus sheath to heal? 6 to 8 weeks. तो आप वैसे ही गलती कर रहे हैं पहले. Don't use wrong sutures in wrong place. Now onwards you'll be registrars. All of you move on in life. Don't use rectus sheath closure with Vicryl. Don't use any absorbable suture for any tough structure. It doesn't work. For skin, you don't need it for more than 7 days. So you use simple suture, silk, or whatever. You can even use Vital Plus, which will be disappearing, absorbed in 7 days. Because you need it for that long. So it is not decided by your will, it is decided by the tissue's will. Take that into account. So absorbable, non-absorbable, synthetic, non-synthetic. And then ideal suture in the center. Ideal suture is monofilament, least reactive, cheap, and absorbable. Presently, is there any ideal suture existing? The answer is no. The closest to ideal suture is PDS. Okay? Any questions? Any questions from anything? You seen that patient today? See a breast? What did you find? Diagnosis.
So there were 3 patients. One had left.
Corner patient.
So inflammatory breast carcinoma left side with the lymphedema of the left upper arm. So I could not examine the axilla because
Can you examine the axilla in these patients? Can you examine the breast in these patients? Was there any lump felt?
no, sir.
Why do you call it inflammatory breast carcinoma?
So edema, induration and edema involving more than 3/4 of the breast without any underlying lump.
So 50%.
Less than 3 months.
Occurring in less than 3 months, 4 months time. Duration is very important, which is what confuses to be implemented. So short galloping course with erythema all over the breast, no lump palpable. What is the cause of pode orange? Not erythema hoga. You got me wrong actually. Erythema nahi bola. Pode orange occupying more than 3/4 of the breast. Inflammation-like picture. What is the cause of pode orange in these patients? What actually is this disease? Inflammatory breast cancer. It's a separate disease, which was described by Lee and Tenenbaum in 1920. They described that this is not breast cancer of its normal type. Here, very early, the tumor thrombi go and block the lymphatics, and they spread it all over. So, wo jo pode orange, which happens in the patch in carcinoma breast, it occurs all over the surface, and it is differentiated from inflammation in locally advanced breast carcinoma by the test 3/4, less than 3/4. But there will be a history of a lump, LABC, and then inflammation happening. Classically, in inflammation in LABC. But in inflammatory breast carcinoma, there is no such time. It happens very quickly. And lymph nodes are invariably involved. If there was a patient with just a lump in this case, when we kill,
Yes.
and the edema of the upper limb, what would be the diagnosis?
So blockage of the lymphatic that is causing the
What would be the stage?
so sensitivity N2.
So N2 is implied if you have fixed axillary nodes, fixed to each other or to axilla, or no nodes but there is lymphedema, because that means the same thing. Lymphedema can only happen if they are fixed to the axillary vein. So this implies already a late disease. We have admitted her for core needle biopsy. She'll be back on Monday for exam. They are always managed by neoadjuvant chemotherapy first. Upfront surgery is not done.
So if skin is fixed to the limb, but there is no signs of skin involvement, like pode orange certain expression, what will be the
The skin is fixed, it is fixed. Pode orange is a fixity of skin only.
Skin is fixed to the lung, but there is no signs.
If the skin is fixed to the lung, it is
Can you
before